purpose of this seminar is to illustrate the anatomy and histology of the temporal bone as seen through the laboratory microscope. The drawing at the lower right-hand corner shows the level of the cut through the temporal bone, and the H&E stain illustrates the actual anatomical structures found at the level of that cut. This is a cut through the area of the geniculate ganglion. We see the genu of the facial nerve as it turns to go posteriorly into the fallopian canal. Here is the takeoff of the greater superficial petrosal nerve. It's this nerve that the surgeon follows through when doing the middle fossa approach in order to find the facial nerve and subsequently the internal auditory canal. Here we see the superior, or the ampulla of the superior semicircular canal, and this represents the nerve that is going to supply that, and just a small cut through the lateral semicircular canal. We are just approaching the cochlea as seen here. This is the malleus and the incus and the incomalleolar joint. These represent cells of the tegmen. This is a higher power of the geniculate ganglion, showing the ganglion cells, the artery that accompanies the geniculate ganglion, the takeoff of the greater superficial petrosal, and again the facial nerve going posteriorly. Here is a cut just below the genu of the facial nerve. We see the facial nerve in the internal auditory canal. The genu would be just superior, and here is the beginning of the fallopian canal. This is the semicanal of the tensor tympani. There is a preparational artifact here in that the muscle has been twisted on itself here and displaced. Here again we see the malleus and the incus. This is the lateral semicircular canal and its cupula. Normally the cupula fills the canal, but in all temporal bone preparations this shrinks and is misleading as far as its size is concerned. This is the beginning of the takeoff of the tensor tympani tendon at the cochleariform process. This is an enlargement of the cupula of the lateral semicircular canal, showing the shrunken cupula, the sensory epithelium, the neurons, and cell structure of the ampulla. This is another cut just below the genu of the facial nerve. Here we see the portion entering the internal auditory canal and the beginning of the fallopian canal. The lateral semicircular canal, the three turns of the cochlea just barely coming into view. Here again the tensor tympani muscle and the beginning of the turn to head toward the malleus of the tensor tendon and part of the cochleariform process. The beginning of the eustachian tube. This is an enlargement of the superior vestibular nerve ganglion, or Scarpa's ganglion, showing the ganglion cells and the neurons in the interstitial tissue. Here is a cut further down, not quite to the mid-medullary section of the cochlea. We see the three turns of the cochlea, the facial nerve, the superior vestibular nerve, again the facial nerve in the fallopian canal, the lateral semicircular canal and its ampulla, and the beginning of the vestibule containing the utricle and saccule, which we will see better later on. Here is the tendon of the tensor tympani going across the middle ear space to attach to the malleus, the body of the incus and its tendon attaching it to the temporal bone. The carotid artery is here, and here are the sympathetic nerves that accompany it. This shows the finer structure of the cochlea, which we'll see later in even higher magnification, the organ of Corti, the tectorial membrane, which normally rests on it but is usually displaced during the acts of preparation, the heliocatrema, the stria vascularis, the spiral ligament, and the interscalar septum of bone. This is the horizontal portion of the facial nerve showing a rather large dehiscence in its osseous canal. We find this dehiscence present in at least 30% of temporal bones. The surgeon doing stapedectomy would be working in this area and might well injure the facial nerve unless he exercised great caution. This is the tympanic membrane at the level of the neck of the malleus. Notice in this area there is no fibrous layer such as we see here, and it is in this area that a primary acquired cholesteatoma can occur due to growth of the epithelium into unresolved mesenchyme in this area should it persist after birth due to a faulty eustachian tube. Here we see an adhesion stretching from the neck of the malleus medialward. These small adhesions are very common and seem to play no part in any type of conductive hearing loss. This is the tendon of the short process of the incus linking it to the temporal bone. This is bone dust accumulated at the time of the removal of the temporal bone. And the insertion of the tendon of the incus. This particular tendon is a good landmark at the time of doing tympanoplasty with mastoid, attempting to find the facial recess, because if the incus is gone, this invariably remains appearing as a little piece of white tissue, almost representing a cholesteatoma. This is a higher power of the organ of Corti, showing the pillar cells. It doesn't show on the television, but there is a neuron traversing the tunnel. Here are the three outer hair cells, the supporting cells of the organ of Corti, the inner hair cell. Again, the tectorial membrane is displaced. This is a cut at the level of the oval window. We see the footplate of the stapes, the posterior crus, the stapedial tendon attaching to the neck of the stapes. We are below the midmedullary section in the cochlea here. We see the cochlear nerve, vestibular nerve with its ganglion. The saccule is here. Here is the internal the internal carotid artery and the sympathetic nerves accompanying it. There is an anomaly in this temporal bone in that the chorda tympani is taking off quite high, actually above the stapedial muscle. The origin of the chorda can occur anywhere from this level to outside of the temporal bone. Here we see the lenticular process of the incus, the malleus handle. The facial recess and tympanic sinus are two very important spaces to the otologic surgeon. For the sake of orientation, here is the cochlea, the tensor tympani muscle, the stapes, the manubrium of the malleus, the posterior semicircular canal. The surgeon enters the middle ear through the facial recess between the facial and the chorda tympani nerve. This allows him a more adequate visualization of this area than he would have through the ear canal. In this normal temporal bone, the tympanic sinus is very deep. Fortunately, in most chronic ears, the inflammatory process prevents complete pneumatization, and here we see a very small tympanic sinus. Here is the stapedius muscle and the facial nerve. This is a horizontal section of the oval window showing the stapes footplate. Notice that it is mostly cartilage. Only this small rim here is bone. This is why a fragmented stapes does not readily heal. The interesting point here is the proximity of the supporting structures of the utricle to the stapes. It is conceivable that when the stapes is removed, that the endosteum here could pull on this and cause a disruption of the utricle. This is a vertical cut showing the proximity of the posterior portion of an otosclerotic footplate to the supporting structures of the utricle. We see here the sensory epithelium of the utricle. Again, it is possible to conceive that by extracting this, one might pull on the endosteum and damage the utricle. This is an otosclerotic focus here and here. Here we see the facial nerve. This is the sensory epithelium of the utricle. We see the sensory cells here and their supporting cells, the neurons to and from the sensory cells, and the debris of the otoconia left behind after the calcium is removed during the decalcification process. This is the internal carotid artery adjacent to the eustachian tube, and we see a very thin layer of bone separating the two. In some cases there is no bone here, and the artery is in direct contact with the wall of the eustachian tube. Another shot of the cochlea, the organ of Corti, showing the tectorial membrane in its normal position. Again, the stria vascularis, the spiral ligament, the spiral prominence, and the Reissner's membrane. This is slightly displaced. It should make a straight line. In cochlear hydrops, it is bulging. Here we see a cut through the basal turn of the cochlea. And this is the basal turn showing the takeoff of the cochlear aqueduct and the vein that accompanies it in a separate channel. We see also the vestibular aqueduct, which we'll see later in higher power, the facial nerve, the niche of the round window, the ampulla of the posterior semicircular canal. Here is the tympanic membrane and the long process of the malleus embedded in it. This shows the paralymphatic aqueduct as it appears under the light microscope. It appears to be filled with a areolar type tissue. As we'll see later, this is a little misleading under the light microscope. This is another section showing some blood cells within the duct. This was in a patient who had had an intracranial hemorrhage. This is a scanning electron microscopy picture of the cochlear aqueduct showing that it's actually filled with a mesh-like tissue, and these spaces are just about large enough to permit the passage of a red blood cell. Apparently this acts as a type of impedance mechanism to cut down on the rapidity of the flow of and the pressure changes between the spinal fluid and the perilymph. This is the endolymphatic duct showing its cuboidal type epithelium, and in 40% of cases we find these peculiar hyaline bodies. The reason for their presence is still obscure. However, there is an association with the number and size of these with the degree of sensory neural loss, particularly high tone, and vertigo and tinnitus. This relationship is being analyzed at the present time. This is another cut through the basal turn of the cochlea, and we see the round window membrane, the spiral ligament, and just the lower portion of the basilar membrane. Here is the carotid artery, the facial nerve, the chordotympany nerve, and the stapedius tendon. Of interest here is a very small fracture line running between the ampulla of the posterior canal and the round window niche. This has recently been described elsewhere, but the other author and ourselves have found it is constant. It is filled with fibrous tissue and may not represent a fracture, but some anatomical variant that the purpose of which remains obscure. The next section will illustrate a vertical cut through the area of the vestibule and oval window. Here we see the stapes in the oval window, the vestibule, the basal turn of the cochlea. There is a preparational artifact here showing a gap, the round window membrane, the facial nerve, the semicanal of the tensor tympani muscle, and the tegmen tympani. Notice how very thin this bone is here. This represents the middle ear space. Thus we have taken a trip through the temporal bone via the laboratory microscope. The trip illustrates how close some of the vital structures of the temporal bone are to the surgical field. These include the vestibule, cochlea, carotid artery, and facial nerve. Injury of any one of these with the drill may lead to serious consequences. I hope this will make us all a little more humble during our surgical procedures.